7 years.
8 years.
I did fall pregnant and I had a miscarriage.
It was the worst pain in my life.
I'm destined to be a mother.
Your heart's become our world.
We can't be silent about it.
Women don't want to talk about this. But what if we put our problems there for everyone to see, to help other people?
The Salome range of products tackle issues of infertility, menstrual pain, and heavy menstrual bleeding.
Next, we are going to talk PCOS throughout a woman's life, and that would be by Dr. Marienus Trouw. I'm just going to read a bit about Dr. Trouw. He studied medicine at the University of Pretoria and qualified as a gynecologist in 1984. He completed infertility and endoscopic training in Leuven, Belgium, as well as in Copenhagen, Denmark. Dr. Trouw is associated with the University of Pretoria's reproductive unit at Steve Biko Academic Hospital and is actively involved in training reproductive medicine specialists. Welcome, Dr. Trouw. You can take the stage.
Good morning, and thank you for the opportunity. Now, polycystic ovarian syndrome, or PCOS, or PCOS, that we talk about today is a very common condition, and one would think that the fact that it is so common, it is well understood, but it is something that, from my side, I think that there's a lot of problems in terms of the management, and we have got a lot of unsatisfied patients in the end. So what I'm going to try and do is to highlight what I think is important about the condition. And I think the first thing is obviously what is PCOS. And I think that is, from patients' point of view, a very difficult concept to understand. Because if you, for instance, go to the Kruger National Park, you come back with fever, you go to your GP, he will say, maybe you've got malaria, we will draw blood, and they will then be able to pick up the parasites of the malaria that causes malaria in the woman's blood, and the diagnosis of PCOS will be made. Currently, with the whole COVID pandemic that we've got a diagnostic test. So a patient will go for a PCR swab, and it will come back that she's got will have COVID or not. Now, we don't have such a test for PCOS, because PCOS is a syndrome. Now, what is a syndrome? A syndrome is actually man-made. It is a group of signs and symptoms that, when they occur together, they will be categorized as a particular abnormality or condition. Now, you've got lots of syndromes around, of which Down syndrome is one of them, but it is actually not anymore a syndrome, because we've got genetic testing now. So it's actually now a known condition. We would normally make the diagnosis of PCOS using so-called diagnostic criteria, which I will explain to you just now. Now, classic PCOS is a condition which will always have increase in male hormone with abnormal menstruation or absent menstruation, and the woman would not be ovulating. Now, what we mean by increased male hormone, they will normally either have acne or male-type hair growth, for instance, moustache, beard, the inner thighs, or the lower abdomen. PCOS has got significant public health issues because of its reproductive, metabolic, and psychological features. And it is very common. It will affect about 8 to 13% of all reproductive aged women. As I said before, there's no diagnostic test. We know today that there are genetic links to the condition, but it is very complex, and there's no specific genetic test. You know, there's a lot of things about genetic testing going around, but unlike, you know, for instance, somebody with cystic fibrosis, where there's a single gene that causes it. It's not the same with PCOS. So with PCOS, you know, there are what is called candidate genes, and none of them are absolute. So you can't make the diagnosis by purely doing a genetic test. This slide is important in the sense that it illustrates that PCOS is not just for women with infertility. It starts at a young age. Now, we know that, that the menstrual abnormality starts even just after the menstruation starts in teenage years. Frequently, these girls might present with increased male hormone, acne, and even increased hair growth. It will have an effect on contraception, on sexual health, on infertility. But later in life, because of the metabolic consequences, it will have an impact on cardiovascular disease, even increase in certain types of cancers. So a woman with PCOS needs to be managed in a holistic manner, and a whole lot of specialities are actually involved in the management throughout a woman's life. And it's important to understand that, and not only think in a little box about the fact that you might not ovulating and can't fall pregnant. Now, the impact is obviously psychological. You know, it causes anxiety, depression, and have negative body image. On reproductive health, patients will have irregular periods or absent periods, the increased hair growth that I talk about, and obviously infertility, which we're talking about mainly in this show, and also pregnancy complications. As I said before, there's an increased risk for insulin resistance, metabolic syndrome, type 2 diabetes, and also cardiovascular disease due to the increase in cholesterol. And what is very important is in a lot of studies which was done, you know, most patients with PCOS is dissatisfied with the care that they've got, and that's an international trend. Now, about 2 years ago, there was guidelines published, and you can get it on different websites, which actually are trying to put down guidelines in terms of the diagnosis, but also in terms of the management of PCOS. How they did it was that experts from different countries. There was also a group from South Africa, which was run by Prof. Jeffrey van der Spy of University of Cape Town. I was also involved with that. And what was trying to make was to try and make sense of the diagnosis and management, and also to sort of have common ground in terms of how to diagnose and manage the condition. Now, to make the diagnosis, as I said before, there's no diagnostic test, but there is diagnostic criteria. Now, there are three what we call major criteria, which the first one is the irregular menstruation, which is cognizant of not ovulating. So the patient has got an absence of ovulation. The second one is an increase in male hormone, meaning testosterone or other male hormones. And the third one is the polycystic ovaries, which one can see on the ovaries, which is not really cysts, but too many what we call follicles. Now, the symptoms of PCOS is diverse. You know, this is a busy slide, but you know, it can present with the menstrual abnormalities, the hair growth, the diabetes, the infertility, insulin resistance, and also the psychological problems. So it's important to understand the complexity of the possible symptoms. Now, what do we mean by the irregular periods? Now, if the periods are either too short, meaning shorter than 21 days, but importantly, most patients with PCOS will have long intervals, and that is longer than 35 days. Or it is when there's less than 8 cycles in a year. That would then be regarded as being oligomenstruation or too few menstruations in a year. Importantly, you also get some patients who's not ovulating who have got regular cycles, and then we might want to confirm ovulation using certain tests, and then we normally would do the progesterone at a certain time of the cycle. The increased male hormone can either be clinical, meaning there's symptoms, or it can be biochemical, where we measure the testosterone. So that is the second major symptom of the PCOS. And then the third one is the abnormality in ultrasound. Now, this is a very classical picture of so-called polycystic ovarian morphology. And all of those little black spots you can see on the slide there are actually what we call follicles. Now, all women will have follicles, but there's fewer in a normal ovary. And due to the hormonal imbalance, those follicles will increase. Now, what's very important is that the term cyst in the name polycystic ovarian syndrome is actually wrong, because a cyst is normally bigger, and you get different types of cysts. Now, a polycystic ovary, sometimes people think that because they've got that will contribute to having pain. But a polycystic ovary is not painful as such, like a cyst can sometimes be. So there's a difference between a cyst and polycystic ovarian morphology, or the polycystic ovarian appearance. Then, very importantly, there's ethnic variations. Now, not, some for instance, the Caucasians is milder, the Middle Eastern might have more increased male hormone, the Africans might have more metabolic problems. So not everybody looks the same. Also, not all PCOS patients look the same. So some patients might not have the increased male hormone, but only the ovulation problems and the typical picture on ultrasound on the scan. Yes, you get a classical appearance, but a lot of patients might have a different appearance. Now, what's very important is there's common misperceptions, and a whole lot of colleagues, unfortunately, do patients' blood insulin levels and say that your insulin is high, so that means now you've got polycystic ovarian syndrome. So that's not true. So yes, insulin resistance is part of the condition, but it doesn't mean that that all patients will have it. The other is that if a patient is obese, immediately they would say that she's got polycystic ovarian syndrome, which might also not be the case. And the other very important one is that people will have a scan and have the polycystic ovarian morphology and also being put the label of PCOS. But about 30% of young women will have polycystic appearing ovaries, meaning will not have the condition. So if you only have got the polycystic ovaries on ultrasound, it doesn't mean you've got the condition unless you've got the other problems. As I said before, it can't be diagnosed with genetic testing. Now, the management is very important. Firstly, is diagnosis, as we talked about now, is either PCOS is either not diagnosed or overdiagnosed, and the idea of the guidelines is to try and have standardization of that. There is no silver bullet. There's no cure. There's no single treatment that will just take everything away. It's normally a stepwise approach where we do different things. Lifestyle modification is the basis of most patients in terms of management, especially obviously the obese group of patients, which might be the majority, but also you get the thin group. Then the treatment will focus on the specific symptom. So you would look differently on a teenager with irregular periods and acne than you would do on a patient that wants to fall pregnant, or about a 40-something-year-old which is now at risk of having diabetes. So you need to be focused on the specific time frame and the specific condition of the woman. Now, which is very important is that it is a difficult journey, but you must stay in the journey. And what I mean by that is that you and your doctor must have a plan. There must be a treatment plan where you say, I'm going to do this for so long, and then we're going to do the next step and the next step. Because too frequent we see patients that have been trying to fall pregnant maybe for 5-6 years, but had 1 or 2 attempts at ovulation induction. And that will not help. So you need to stay part of your treatment. Lifestyle interventions, as I said, is very important. It's multi-component. We need to look at diet, exercise, and also behavior strategies. And all PCOS women with excess weight needs to be encouraged to lose weight, because the central obesity will contribute to the insulin resistance. Modest weight loss, as little as 5 to 10%, will contribute to having a significant impact on the hormonal balance. And one need to set realistic goals. Now, there's no diet which is going to PCOS diet. You know, there's a lot of things which you might read on the internet of this is a PCOS diet or that. In the end, calories count. You need to have a calorie-restricted diet, and you need to have about a 30% deficit of calories per day. You know, and obviously that needs to individualize, and we frequently would have dietitians helping us there. And, you know, in terms of the amount of calories that you need to take in. Exercise, very important. You need to have a minimum of about 250 minutes per week. Varying exercises. We know today that strength exercise is probably as important as cardio. You know, a few years ago, obviously every focus was on cardio. You need to minimize sedentary lifestyle, and you need to be focused. You know, the so-called SMART, where you have got you've got realistic targets. So if you're going to have somebody that never exercised, start off with 10%, 10 minutes for a week and increase to 15 the next, you know, and build towards goals. Because otherwise, you know, people get despondent very quickly. Very important one, need to look at the psychological part of it. A lot of these patients might be have anxiety, depression, and body image issues. And one need to obviously take note of that as well. Very common supplement which is used today is there's a whole lot of inositol containing products available. There's very limited evidence that it really makes such a huge difference, but you know, because it doesn't have a lot of side effects, the guidelines say that you can consider to use it, but they also see that inositol is at this point probably still experimental, and because of the fact that there's not strong evidence that it will be beneficial. Now, how do we manage increased male hormone? Now, here, you're talking about medical treatment from this forum. Obviously, you need to do it with your doctor, but in principle, you need to obviously remove unwanted hair. You can wax, laser, electrolysis. Then you need to have hormonal treatment. And the contraceptive pill is an important part of that because it blocks the male hormone production in the ovary, but also blocks the effect on the hair. So there would be a hormonal treatment as well. Your irregular cycles normally would be, in patients that don't want to fall pregnant, would be put onto the pill. But if you want to fall pregnant, it's a useless exercise to use the pill because it will not make any difference in terms of falling pregnant. Now, ovulation induction, I think very importantly, you don't need to prolong the use of ovulation inductions. We would normally talk about 6 months, you know, maximum. As I said before, you need to have a treatment plan, and you need to exclude pregnancy before you start. First-line treatment today is letrozole, or is the most common one is Femara, because it got lower risk for multiple pregnancies and slightly better pregnancy rates than the Clomid that we used before. Clomid is still used and can still be used, although we think that the pregnancy rates is lower. You can add metformin, which is a diabetic drug, which frequently can enhance the effect of your Clomid or your letrozole. Metformin alone is not as effective in terms of stimulating ovulation, so we would normally not recommend that, and we would normally use it with one of the other agents. The injections, you know, there is very important that it is second-line treatment, and very important that there's risks involved. It's costly, there's expertise involved. You need to properly monitor it with ultrasound, and we don't want to see this. You know, this is 5 babies after the use of gonadotropins, and it was an absolute disaster for the patient. Luckily, I was not involved. You also can get ovulation, ovarian hyperstimulation syndrome from the injections. So this must be done by people who have knowledge in how to use the drugs. You can also do surgical treatment. We don't see that as first line, but the so-called laparoscopic ovarian drilling, where at the time of laparoscopy, one with a cautery burn little holes into the ovary, which can stimulate in patients that are resistant to the normal treatment in terms of stimulating ovulation. Then Also then IVF. IVF, you know, obviously if there's other indications, it will be done sooner, but normally IVF is reserved in PCOS patients where the other treatment modalities have not had satisfactory effects. The thing of IVF in PCOS patients, they're difficult to stimulate. They either don't respond or they can make a lot of eggs. So once again, you know, there's expertise involved, also with the high risk of hyperstimulation syndrome. Then lastly, one need to look at the long-term effects. You need to look at screening for gestational diabetes when the patient is pregnant, but also for impaired glucose tolerance. And then all patients with PCOS should be assessed for cardiovascular risk factors. You know, your cholesterol needs to be, your blood lipids, cholesterol needs to be tested, and that needs to be done throughout your life because you might not have the impact of the polycystic ovarian syndrome, but you know, when you're getting older, but the risk factors for the cardiovascular disease will stay. Then my take-home message is that the correct criteria for diagnosis is important. One must understand that it is something that affects a woman not just when she's young, but throughout her life. Weight loss and exercise is sort of the mainstay for the obese patients. You need to tailor your treatment according to your problem. Your gonadotrophins is, you know, the injections, you know, should be done second line. It must be done by experienced clinicians. And also the laparoscopic ovarian drilling is something that one can offer, but care must be taken not to, you know, and also be done by somebody that's got knowledge about fertility, not to damage the ovary. And then the IVF, we think, is a third-line treatment. So that is my story about PCOS. Thank you.
Thank you, Dr. Trouw. We really do appreciate you taking the time today to come and give us your expertise on PCOS. We do have a few questions for you. Let's start with what role do carbohydrates and sugar play in PCOS, and should I avoid them, specifically in relation to insulin resistance?
I think that obviously is a very important topic, but if you look at all good diets, you should avoid complex carbohydrates and you should avoid sugar. Now, in terms of whether that is really important in terms of a calorie restricted, you know, I think there are different opinions. There was a very interesting study which was done at Tygerberg a few years ago by Prof. Igno Siebert. It was actually part of his PhD that he did. And they found that the intake of fruit was actually detrimental to women's weight loss. And there they thought that the fructose has got a specific bad effect. Now, we've all been taught to eat a lot of fruit when we're young by our parents because that's good with containing vitamins. But especially some fruits got very high rates of fructose. Yeah. And they found in their study that women with a high fruit intake had more difficulty in weight loss. So I think that what one must understand about the whole insulin resistance thing is that it's a bit of a vicious circle. So if you're going to lose weight, your insulin resistance is actually going to improve. So what it comes down to is that you know, I think that one thing that everybody is agreeing on is actually to, you know, in any diet is to limit you know, your complex carbs and also your sugar intake.
Excellent. Okay, so somebody wants to know about PCOS. Does it contribute to the development of diabetes?
All right. So that's very important, especially in your obese PCOS patients. They've got an extremely high risk of developing type 2 diabetes later in their life. You know, so and that's sort of where my topic comes in. You know, you need to be in the game throughout your life. You know, it is not something that will leave you, unfortunately.
Yes.
But it is something that you can take care of. And what I wanted to say, and I always tell patients with PCOS, because a lot of them come with the idea that they will never be able to fall pregnant. And some of them actually tell you that some doctors have said that they can't fall pregnant. But in the end, the PCOS actually for falling pregnant actually has got quite a good prognosis. You know, it might take some time. It might take different treatment options sometimes to get to the goal. But the prognosis ultimately is good. I think the long-term thing, as we said about the diabetes, one need to obviously be aware of and look at.
Okay, great. And is ovulation tracking a good way of monitoring your cycle alongside the ovulation-inducing medication? How long should I be on ovulation-inducing medicine at one time?
Yeah, all right. So I think what's very important is that the way, you know, some people some doctors will monitor their patients every month with scan. Now, in the beginning of the treatment, when we're using things like letrozole or Clomid, I would normally do the initial scan in the first month, and if the woman is definitely ovulating and also not making too many follicles, that's the other thing, I would then advise them to obviously use it at home. Okay. And then ovulation tracking by means of LH sticks, the urinary sticks, might be useful because it will help with timing. It's probably not essential. You can also have the so-called fertile window concept, where you have about 5 to 7 days around the time of ovulation having regular intercourse. How long should you go? I normally would say that with a specific modality, for instance, you're going to use Clomid or Femara, not to go longer than 6 months.
Okay.
So I would, you know, I think it's important to set out a plan to say, okay, you're going to go your weight loss. We're going to start with Femara. If the Femara work, we might go for 6 months. If it doesn't, you come back and then we go to the next step and the next step. So most people will fall pregnant with simple things. Most people will not need, for instance, IVF with PCOS. Most people will fall pregnant with simple things. But you need to obviously stay in the game. If you're unfortunate to be the one that needs the IVF, not to wait 5 years or 6 years to eventually get there.
Yes, yes. Okay, great. And if my mom has PCOS, what are the chances that I do?
As I said, there is a genetic link. It's not genetics as we normally would think it. So the specific percentage is not that well thought out, but there's definitely an increased risk.
Okay, and then how would I check if I have it or not?
Okay, so to make the diagnosis, you go back to that Rotterdam criteria. Yes. So the three things is that the irregular periods, the increased male hormone, and the polycystic ovaries on scan. And to make the diagnosis, you need to have 2 out of those 3 criteria. Okay. So that's the only accepted way of diagnosing it.
Okay, great. Okay, so when trying to conceive with PCOS and having irregular periods or amenorrhea, you know what I mean. Yeah. What can be done or taken to get them back to normal with the idea of falling pregnant? Yeah.
So the whole thing is that's the classical presentation. So the patient will come with not having periods and wanting to fall pregnant. So you go and look. If the patient is overweight, set a realistic goal, 5 to 10% weight loss. So that's the first thing to do. Secondly, is then to go onto some medication to stimulate ovulation. So you go with your tablets first. If your tablets fail, you will then either consider the injections or then maybe the surgery. Yeah. So that is the classical approach that one will do. What I think is quite odd sometimes is that people are being put onto the pill to have periods. Now, yes, the pill will give you periods, but it will not help you to fall pregnant because it will actually prevent you from falling pregnant. So the whole issue is then, is then once again, so to have a plan. So as I said before, weight loss, exercise, you know, then you can add your inositol if you want to. Sometimes we will use the metformin, the glucophage, and then the drugs to stimulate ovulation.
Okay, so you do some natural supplements, etc. You do suggest.
Okay.
Great. If we haven't reached your question today, please feel free to email them to fertility@liveevents.africa, and we'll ask them to Dr. Trouw, and we'll get back to you within a couple of days. Thank you so much, Dr. Trouw. We really do appreciate it.
Thank you very much. Thank you.
Bye.
Bye.
7 years.
8 years.
I did fall pregnant and I had a miscarriage.
It was the worst pain in my life.
I'm destined to be a mother.
Yeah, it's become our world.
We can't be silent about it.
Women don't want to talk about this. But what if we put our problems there for everyone to see, to help other people?
The Salome range of products tackle issues of infertility, menstrual pain, and heavy menstrual bleeding.
Seven years.
8 years.
I did fall pregnant and I had a miscarriage.
It was the worst pain in my life.
I'm destined to be a mother.
Yeah, it's become our world.
We can't be silent about it.
Women don't want to talk about this. But what if we put our problems there for everyone to see, to help other people?
The Salome range of products tackle issues of infertility, menstrual pain, and heavy menstrual bleeding.